Alterations in cognition and sensation, ear disorders. Ear disorders can occur throughout the life, and nurses play a vital role in preventing hearing loss. Hearing impairment can be mild, moderate, severe, or profound. Causes include a conductive loss from obstruction in the outer or middle ear, sensorineural loss from damage to the inner ear. Mixed hearing loss will incorporate both conductive and sensorineural loss, or central hearing loss resulting from injury or damage to the nerves. When we talk about presbycusis, this is hearing impairment that is associated with aging. Hearing loss can result from repeated exposure to excessive noise. Risk factors for hearing impairment include family history, congenital malformations, ototoxic medications, recurrent ear infections, bacterial meningitis, and perforation of the tympanic membrane. Consequences of hearing impairment will depend on the client's age and the severity of the impairment. If the client, for example, is less than 3 years old, this will affect their language development, their ability to communicate, and their safety. These clients, a lot of times with hearing impairment, will experience tinnitus, which is ringing in the ears, or decreased hearing. Medically, we may need to set the client up with hearing aids, determine that the ear is not impacted with cerumen, which is one of the major causes for hearing deficit in the older adult. As they age, they begin to lose some of the fluid in the body, which then causes that cerumen, that earwax, to be dry, so it can become impacted in the ear. We need to provide an alternate method of communication and maybe some frequency modulation systems. Surgically, there might be the opportunity for a cochlear implant or a bone conduction device or a semi-implantable hearing aid. It is important as nurses to observe for hearing impairment. These clients will exhibit behaviors such as leaning forward to try and hear better, turning towards whoever is speaking so they can hear. They may be cupping their ear. They may have issues with speech clarity. Very important for us to provide appropriate support. As far as communication with hearing loss, there are a variety of ways that we can communicate with these clients, such as American Sign Language, speech reading, closed captioning, a headset that has amplification. That TDD TTY is a telephone they can use. A hearing assistance dog, support persons who can communicate by signing. As far as nurses, when we are dealing with someone that has a hearing deficit, make sure that you are eliminating background noises and make sure that you are standing or sitting on the side of the client's better ear. Make sure that they have appropriate light and make sure that you have their attention prior to speaking. Speak clearly, but do not shout at them. Use the lower tones because clients can usually hear those better than the higher tones. If the client doesn't understand, don't automatically think that they're confused. Try rephrasing the statement and saying it in lower tones. Be very positive and provide them some paper and pencil for communication if necessary, or a whiteboard. Again, impacted cerumen is accumulated earwax. It does interfere with sound that's carried on airwaves, and it's really common with excessive thick or dry cerumen, especially in the older adult. These clients may experience otalgia, which is going to be pain or fullness in the ear, diminishes the hearing. They may have an orange-brown accumulation of cerumen. They may have conductive hearing loss. We need to make sure these clients stay well hydrated. We may need to irrigate the ear to remove the wax, or use a cerumen spoon to help remove the wax. Nurses should always inspect the ears, maybe irrigate or use ear drops to help keep that earwax soft, and educate clients to not use cotton-tipped swabs or objects to clean the ears. The cotton-tipped swabs can just push that cerumen further down towards the tympanic membrane and further increase impaction. And the sharp objects, of course, can cause some damage. True or false? Impacted cerumen interferes with sounds that are carried on airwaves. True. Otosclerosis is a bony overgrowth of the stapes and is the most common cause of hearing loss in the adult. Now, the stapes is one of those bones in the middle ear. It has an unknown cause, but it may have a hereditary cause. Basically, what is happening is we have a decreased vibration of that stapes, which diminishes transmission of sound to the inner ear and creates that mixed hearing loss. These clients will have a progressive bilateral hearing loss. They may have nighttime tinnitus, and the eardrum might be pinkish orange in coloration. So diagnostically, we can do the audiometric test or a CT scan. There's no cure for this. These clients may require hearing aids, but we can do a surgical procedure called a stapedectomy, where they go in and actually remove the stapes. Nurses provide alternate methods for communication. Postoperatively, position the client on the non-operative side. The hearing, the clients need to be aware of this, might be decreased immediately after surgery because of swelling. Safety measures should be provided for dizziness because the ears, that's part of their function is to provide balance. So if they have vertigo, they are at risk for falling. We also need to prevent dislodgement of any surgical procedures that were done by the client coughing or sneezing or vomiting. So we also need to decrease straining. We do that by administering stool softeners and avoiding heavy lifting. We should encourage our client to not get the ear wet until it's okayed by the surgeon. Vertigo is a symptom of a disease, and it's basically the sensation of movement when there is no movement. It's caused by a disturbance in the inner ear, and it includes balance and stability issues. We have objective vertigo, where the client is not moving but has the sensation that everything else is moving, and subjective vertigo, where the client feels motion but the environment is not moving. Now, motion sickness is a type of vertigo. It's caused from repeated and constant motion. We treat that with antihistamines or anticholinergic agents. There's also benign paroxysmal positional vertigo, which is caused with head movement, and that would be treated with a medication called meclizine or vestibular rehabilitation. Treatment will be based on the cause. Again, make sure that you assess safety issues or fluid balance issues in the event of nausea and vomiting. And when things are spinning, we do tend to get nauseated. And when we're nauseated, there's always the possibility that we may vomit. And when we're vomiting, we may get very pale, so we have that pallor, and diaphoretic prior to upchucking. Ototoxicity is the adverse effect of certain medications on hearing structures. Symptoms include tinnitus, sensorineural hearing loss, lightheadedness, vertigo, nausea, and vomiting. Some symptoms might be reversible with the stoppage of the drug, depending on which drug it is and how much the client has gotten and how long it takes to stop the medication. Those drugs would include salicylates. It also includes like ibuprofen, loop diuretics, quinine, and aminoglycosides. Aminoglycosides are one that we have to be very cautious. Let your client know that if they experience ringing in the ears, that we need to stop that medication immediately. We also need to monitor these clients for hearing changes. Which medication should a patient with Meniere's disease avoid? This would be aspirin. Um, Met, Meniere's disease is going to be one of your inner ear disease issues. And these clients may have extra fluid in the ear.